I'll be speaking on corneal dystrophies and degenerations, and thanks to my RP center which gave me the analytical ability to go into depth of these corneal lesions, and this particular knowledge of this particular subject was honed by Peter Lepson, from whom I learned in detail about corneal dystrophies. Initially I used to think it's a theoretical topic, but no longer. It's very common, dystrophies are very common, and it's important to diagnose these things and what layer they are affected, because your management changes according to that. Important thing to differentiate is between corneal degenerations and corneal dystrophies, and not to use the words interchangeably. Corneal degenerations means there is a deterioration or decrease in the function. They may be unilateral. There is no inheritance pattern. They are usually peripheral, related to the vascularization. There is a variable progression, and they may occur later in life. On the contrary, corneal dystrophies are bilateral. They are symmetric, hereditary, appear early in life, avascular, central in location, and slow progress. Briefly going over the different types of corneal degenerations. They may be caused by aging or may not be caused by aging. The ones caused by aging could be arcus senilis, white limbal girdle of Vogt, crocodile shagreen, cornea farinata, and polymorphic amyloid degeneration. All these things occur. It's important to know what they are, and they are not abnormal, and by and large all these things do not need any treatment. Coming on to degenerations which are not caused by aging, they could be lipid, where it may be primary or secondary in relation to the corneal neovascularization. It may be Salzmann nodular, it could be keloid, Tyrrhen's marginal, band-shaped keratopathy. They could be calcareous deposits, they could be drug deposits. Important to know all these things because the treatment for each is usually different. Just going over these certain slides, it's there in the band-shaped pattern, though the thing, a resident showed this case to me as a BSK, but on closer evaluation you can see that these are the yellowish deposits. This was a 25-year-old lady, came with severe photophobia. This is a primary lipoid keratopathy, and they usually have a vessel at the base, very commonly seen from people coming from the desert area, from the Rajasthan area. I've had 4 cases coming from that, and if you really make a slit, you'll see that these lipoid deposits are usually present only superficial, and they respond very well to the DALC, in which the underlying stroma is preserved and patient gets a good vision. Another case is when you get these kind of multiple nodules on the surface of the cornea. Patients are extremely photophobic. I mean, you might be really fighting with the patient to open the eye to see what the lesion is. There may be underlying vascularization. These are the cases typical of Salzmann nodular keratopathy. Pretty common to see. And they do very well with superficial, even PTK in the earlier stage and lamellar keratoplasty in the later stages. These are some of again, one of our patients only, where we had these kind of small crystals deposits and later found out to be cystinosis. Another patient of ours, where we had a patient just presents to you with this kind of a lesion, may give you a definite history, may not give you a definite history. At times the history is not there. These are corneal keloids. Or, not to forget, if you get these kind of small white deposits on the surface of the cornea. They are deposits, they are not infiltration. Sometimes patients are shown to you as corneal ulcers, but these are ciprofloxacin drug deposits. Then there are certain pigmentary degeneration in the form of iron, melanin deposits. Iron deposits could be Hudson-Starley line, Fleischer ring, Stockel line ahead of pterygium, Ferry's line associated with superficial scars in RK or PK or a blood staining. Melanin secondary to medications, especially the epinephrine group of drugs used in glaucoma. And another, just a passing reference I want to give for the topical calcium deposition when you do a EDTA chelation. Now coming to the main topic of cornea, don't get flustered by this long chart, but I'll be dealing with the important type of corneal dystrophies. Remember, the dystrophies are bilateral corneal alteration, they are progressive. They occur after birth and located in the central cornea. Here I am narrowing down to the fact that you know the diagnosis. But let's come to the fact that how do you know that you are dealing with a corneal dystrophy, which I'll be coming to later. It's important to make a very good slit lamp diagram of the cornea, see where the lesion is, and if it is bilateral, symmetric, you know that you are dealing with a dystrophy. In case you find the lesion to be anterior, it could be either a Meesman's dystrophy, or it could be an epithelial basement, or a map dot fingerprint dystrophy. It could be a Rees buckler, or the other name for this is also corneal dystrophy of Bowman's layer. The various important stromal dystrophies we have is granular, macular, lattice. They are very common. Others are Evelino's, gelatinous droplet like you may see occasionally. And another ones to be seen here is central cloudlet dystrophy, which I will be coming to later. Once the posterior structures are involved, you have posterior polymorphous, Fuchs endothelial and congenital hereditary endothelial dystrophies. The primary differentiating feature, whether you are dealing with anterior, stromal or posterior corneal dystrophy, is you can see it by complaint. Anterior corneal dystrophy patient usually comes to you with complaint of recurrent episodes of pain, redness, watering, photophobia, effectively giving you the features of recurrent corneal erosions. They may have blurred vision, leading on to, and because there is an irregular healing of the epithelium, it gives you irregular astigmatism. The anterior dystrophies are seen very easily with broad slit lamp beam. So you really have to be very, very well versed with slit lamp examination, something which I think people tend to ignore. You need to do a broad slit lamp beam or a retroillumination, best seen with dilated pupil. Other ways of examining is rapid. There is a breakup time is very small. And in case, the golden rule is if a patient comes to you with one eye with recurrent corneal erosion, always examine the fellow eye to rule out that the patient might be having an anterior corneal dystrophy. The ones, for the sake of completion, I'm talking about Meesman's, where you get multiple cysts and usually no treatment is needed. Important to see is epithelial basement membrane dystrophy, where you get multiple these kind of fingerprint kind of lesions on the superficial layer of the cornea. They may be like maps, and they're best seen in retroillumination. Just excuse me. Okay, I tend to listen to you. And the others are the corneal dystrophies of Bowman's layer. There are two types in this. One is corneal dystrophy Bowman type 1 or type 2. This is the superficial variant of granular dystrophy. If you get a patient who's got this features of RCE, that is recurrent corneal erosion, with multiple reticular shaped lesions in the superficial part of the cornea leading to opacification, you are dealing with Rees buckler. The hereditary features are always there. The other part is where you get a honeycombing, that is the Thiel-Bankes type of corneal dystrophy. The golden rule for management of anterior corneal dystrophies is basically related to the symptoms of pain, because if we know the recurrent corneal erosion patient usually comes to you with getting up in the morning with very, very severe pain and lid swelling. The treatment is aimed in the management of these RCE features, which could be lubricants, could be patching, use of bandage contact lens. If you find the lesion which is outside the visual axis, do anterior stromal puncture, and if it is in the central area, do a PTK. Other options available are epithelial debridement or superficial keratectomy. So they can be managed with all these things, provided you know that what you are dealing with. If you have lesions which are present in the stroma, we are dealing with stromal dystrophy, and they present mainly due to opacification from the metabolically generated abnormal. It's a deposition of the abnormal material, unlike the anterior dystrophy where there is a breakdown of the epithelium. They are usually painless. The vision is maybe decreased, and they may be painful only if the things like granular dystrophy, which has a superficial variant, which has a feature of recurrent corneal erosion, which may happen in granular dystrophy or it may happen in lattice corneal dystrophy. Don't get flustered by this long chart, but this is easy to remember. A granular corneal dystrophy is autosomal dominant trait. It may appear early in life, but the vision loss is not very common. You might see this kind of patient, especially coming to you for phaco, and may have an associated granular corneal dystrophy. They may have recurrent erosions. The features they have are, they may have a drop-like or crumb or a disc-shaped lesions. As I told you, vision is not grossly affected. The hallmark for the diagnosis is that the intervening cornea is clear between the deposits. And in the later stages, they may be affected due to intermedial scarring. Another thing to differentiate, the periphery of the cornea is spared. It's only a central lesion. And also, whenever you look at the dystrophy, you always tend to look at the family. And you will see that even the next generation is affected. They may not complain to you, but there may be small lesions there. It occurs early in the next generation. Histopathologically, there is a hyaline or the protein of the phospholipid deposits. They may be managed based on, they may need no treatment or a lamellar keratoplasty or a PTK, PK, anything depending upon the extent of the dystrophy. The variant of the granular dystrophy is a avilinocorneal dystrophy, where it is associated with lattice kind of lesions, or a superficial variant, which is I've talked about earlier. These are the different pictures which you may see in case of a granular dystrophy. This is a typical picture which you see, that there are multiple deposits in the stroma and intervening cornea is clear, periphery is spared, or it may give you this kind of a picture where there is a Christmas tree kind of a pattern. This is another part where it's a very, very early granular dystrophy. Vision is not affected. This is the picture of a child of the lady who had a frank granular dystrophy. This is to show you a typical granular dystrophy. If you see the slit, you will see that most of the stroma is affected. This patient underwent DALC, and you can see that there are still some white dots staying, because some of these dots were there at the Decimet's membrane, which could not be removed, but by and large the vision was preserved. This is the mother of this lady who had had the PK done maybe 10 years before and had come with recurrence of the granular dystrophy in the graft. This is another feature of a granular dystrophy, when you get these kind of multiple deposits with intervening cornea clear, periphery spared. Another type of stromal dystrophy is macular dystrophy. It is autosomal recessive. And though the granular dystrophy is autosomal dominant, but you see less cases of granular dystrophy than macular, because macular is more visually debilitating. There's progressive loss of vision. Patients come to you in the age of 20s or 30s. They may have associated cornea guttata. The differentiating feature from granular dystrophy is that you get diffuse clouding of the cornea. And this opacification extends to the periphery. It's limbus to limbus involvement. There are multiple nodules in the center area. And you have basically glycosaminoglycans or mucopolysaccharides, which are deposits. And they stain positive with Alcian blue. The important to remember, sometimes if you forget what is deposit, that's the deposit, we used to remember M is M. If you have a macular dystrophy, it's a mucopolysaccharide which is deposited. They usually need PK, DALC only in selected cases. Important to remember that in macular corneal dystrophy, even the underlying endothelial dysfunction may be there. These are the typical cases of macular corneal dystrophy. One has a set picture in mind that it may be like this, but as the dystrophy progresses, the intervening cornea gets heavily scarred. So it depends at what level of the disease you are seeing the patient. This is how, when you get these kind of macules and intervening cornea is heavily scarred, and cornea typically is very thin in cases of macular corneal dystrophy. Then another important stromal dystrophy is a lattice, is bilateral, autosomal dominant. You get discrete ovoid subepithelial opacities, and then there are multiple lines which are seen. Here there is usually the amyloid which is deposited. Common presentation of lattice dystrophy is in the form of recurrent corneal erosions when you get irregular epithelial surface. And it is not uncommon when I've had patients who had multiple erosions, was seen in the periphery, seen as and diagnosed as herpetic keratitis with dendritic pattern. They were put on antivirals for a very long time before the patients came to us, and we diagnosed to them to have a lattice corneal dystrophy. Differential diagnosis is prominent corneal nerves or vascular changes in interstitial keratitis. This is what a typical picture of a lattice corneal dystrophy is there, very well seen if you do a retroillumination, and if you do a diffuse slit, you may miss. See, when it's a diffuse picture, you are not seeing any of those lines. You are just seeing those small subepithelial opacities. It's only in the broad beam you get to see these things. Another patient of ours, when in the broad beam, you see these kind of, in these lines, you see those lines coming over here, and subepithelial opacities. A typical picture, again, another of a patient with a lattice corneal dystrophy. This was another lattice corneal dystrophy seen in retroillumination, and this is post-PK for the same patient. Sometimes there may be an associated corneal edema also in lattice corneal dystrophy. Confocal, you can see those prominent striae in cases of lattice corneal dystrophy, which just aids in your diagnosis. These longitudinal lines may be prominent corneal nerves, they may be vascular structures, so everything has to be seen in totality when you're examining a patient. Another variant, a mixture of a granular dystrophy and the lattice, is Avellino's dystrophy, when patients have these kind of lattice lines and these deposits. And they're usually families, families of these kind of dystrophies. Another important thing to see is a gelatinous kind of a dystrophy, where we get the mulberry kind of small gelatinous deposits on the surface of the cornea. I've seen 2 patients till now when we get these. Very difficult to examine these patients because they're extremely photophobic. There's a lot of lacrimation. Certain journals have said in Japanese population this is common, but in India, from the Telangana population, you do get to see, I'm sure Prashant can talk about it, about these kind of gelatinous corneal dystrophy. These are the amyloid deposits. Other stromal dystrophies is a Schneider's. It's an autosomal dominant when you get these discoid lesions with which are fine polychromatic cholesterol crystals. This is one thing which I wanted to talk about. Sometimes the patient may come to you with this kind of a cloudy cornea. You may think patient has Fuchs, erroneously diagnosed as Fuchs, but if you really do a broad slit, you will be able to see a crocodile shagreen pattern, usually localized to the posterior part of the cornea. This is a central cloudy dystrophy of Francois. It does not need any treatment. The important thing is to say that when patient has come to you for phaco, you happen to see these kind of cloudy deposits in the cornea, no treatment is needed and a simple phaco would suffice. The differential diagnosis of stromal dystrophies is there could be a haze falling eczema or amiodarone deposits. Other dystrophies to be known are predecimus dystrophy, and then comes to the posterior. I've told you the symptomatology of the anterior corneal dystrophy, the stromal, and posterior corneal dystrophy. In a posterior corneal dystrophy, the presentation, as you know, only the endothelium is affected, it's a corneal edema. Terminology difference, if suppose we have a endothelium is affected and there is no edema, we call it primary endothelial dystrophy. If it is associated with corneal edema, we call it Fuchs endothelial dystrophy. Important to differentiate between the two because the management becomes different. Other important dystrophy is the posterior polymorphous dystrophy, which is usually asymptomatic, and you get multiple vesicle or band-like lesions which are there in the endothelium. It's important to differentiate these lesions from ICE syndromes. If you do the confocal, you can see these kind of multiple vesicles. Again, they're not from books, this is from the patient's confocal. You get these kind of vesicles on the surface of the endothelium. Important one is the endothelial dystrophy, which we are dealing every day when you get guttata. If you have only guttata before the stromal edema, it is endothelial dystrophy. If there is stromal edema, it is Fuchs. You usually get in the 5th or the 6th decade, autosomal dominant. It may be asymptomatic, but the typical complaint is decrease in the vision, usually worse in the morning and may improve later in the day. The diagnostic thing is when you get these, you must be very well versed to do a specular reflection of the cornea to see those tiny excrescences on the Descemet's membrane. They may become confluent to give rise to beaten metal appearance, and pigment on the endothelium should alert you whether you're dealing with endothelial dystrophy. Associated conditions could be OAG, ACG or keratoconus. And there is increased incidence of hyperopia in these cases. You use specular microscopy to diagnose endothelial dystrophy, and differential diagnosis is Gattata in posterior polymorphous or macular dystrophy. Treatment in the early stages may be hypertonic saline or IOP lowering agents, but the current scenario, the treatment is DSEC. So important to diagnose, am I dealing with endothelial dystrophy or a dystrophy with a gross edema where a PK may be needed. This is a gross case I'm showing you of a Fuchs endothelial dystrophy, a severe corneal edema where maybe Basak may resort to DSEC in this case, but I probably would do PK in this kind of a case. And this is the early case of a Fuchs endothelial dystrophy when you see a minimal haze, patient may be 6'18", and if you really see, you see this corneal edema which is mild. These cases do very well with DSEC. The same case progressed over 2 years, had an edema which was localized. If you see the slit, you can see the edema which is in the deeper layer. Sometimes if a 40-year-old person presents to you, a differential diagnosis of herpetic endothelitis has to be kept in mind in these kind of cases. The same case when I did the endothelial dystrophy did very well. The other differential diagnosis to be kept is the CHED, and endothelial dystrophy, which could be autosomal recessive variety or autosomal dominant variety. We see both types of CHED. Autosomal dominant presents in the first 1 to 2 years of life. It is progressive. There is no nystagmus, and pain and photophobia are common. Recessive, it presents at birth, non-progressive, and it usually is bilateral, limbus to limbus, severe corneal edema, thickened cornea, maybe 2 to 3 times increased. And differential diagnosis is congenital glaucoma or birth trauma. We recently had a case where a patient was diagnosed to have severe corneal edema. Surgeon thought it was congenital glaucoma, and due to maybe the patient couldn't get anesthesia, and maybe good for patient because within 1 month we saw everything had resolved, and actually he was a patient of birth trauma. So, and these kind of things always happen. The management case for CHED is whether you do endothelial keratoplasty or a PK. This is a case of a CHED with a secondary BSK over it. We do get times cases which have diffuse ground glass appearance have been diagnosed. This case was diagnosed as CHED and referred to me, but on closer evaluation we found that the child actually had mucopolysaccharidosis and it was basically a case of Hurler's syndrome. So see everything in totality. This is the same case after doing the DALK, and one could get the vision resorted to 618. I'm just showing you some typical confocals. This is the confocal which we get these multiple Gattata, and these are important especially to see if you have, we know what a normal endothelium looks like, but if you have those tiny excrescences and elevations, these point you towards a Fuchs endothelial dystrophy. So just a take-home message after this, if you see any corneal lesion, bilateral, symmetric, think you are dealing with corneal dystrophy. They are not uncommon. Important is to have a very, very good slit lamp. Do not skip it so that it makes the diagnosis easier. So that you can identify what's the site of pathology, narrow down the diagnosis, and in the current scenario, besides PK, there are so many other treatment choices are available. Thank you very much.